Hi, my name is Andrew Evans, and in this video, I'm going to be talking about three different articles that discuss first person experiences and the importance of patient voices in mental health care. And these are the three authors pictured here. We have Natalia Washington, Nancy Nyquist Potter, and Sharifa Tekin. So, in this video, basically, I'll be discussing these three papers. The first one is by Natalia Washington. It's called Contextualism as a Solution to Paternalism in Psychiatry. The second one by Nancy Nyquist Potter is called Voice, Silencing, and Listening Well. And the last one by Sharifa Tekin is called Participatory Interactive Objectivity in Psychiatry. Now, I think that this is going to be an exciting video to do because these are three philosophers of mental health that are currently writing in the field and that have released these papers recently. They've all come out in the last few years, and they all, I think, address this kind of theme of the importance of listening to people who are struggling with mental health problems and the importance of understanding their experiences. So in this video, I'm going to try to link these three together as having similar themes. I do want to note here at the outset, though, that at the very beginning of the Potter paper, there's a um, case study in which a person who has suicidal ideation and suicidality is discussed there. And it might be discussed at different points throughout that paper. I will mention it just briefly here in this video as well. So I just wanted to note that there at the outset. Okay, so why, do we have people writing on the importance of listening to patient voices? Well, if we think about how the mental health care system is set up in the United States, you have the American Psychiatric Association, which creates the Diagnostic and Statistical Manual of Mental Disorders, the DSM. And that really dictates a lot of how treatment is conducted and what can be done medically for mental health conditions. So it really gives a lot of power to psychiatrists and clinicians of different sorts. And sometimes patient voices aren't included in various ways. So what this what these papers sort of have in common is they note that there's these institutional structures that often silence patients or don't take them into consideration. And they point out some problems with that and some ways forward on how patient voices could be incorporated more into mental health care. Okay. One thing I also want to note here at the beginning is just a distinction that comes up in a few different places. There's a difference between calling something epistemic and calling something ethical. So the word epistemic comes from the field of epistemology, and that just has to do with knowledge, right? If something is epistemic, then in some sense it has to do with knowledge or knowers or sort of the ways in which we come to know things. When we're talking about ethical things or ethics, the field of ethics, we're talking about morals, right? We're talking about what's good and bad morally. So some of the authors make distinctions between these or use these words. So I just want to note from the outset, this is an important distinction to keep in mind. Okay, so starting with Washington, in this paper, she really is worried about paternalism. So that is the topic she discusses, the problem of paternalism. She says, quote, "Without a properly justified normative theory of mental disorder operating on our schools, prisons, clinics, and other institutions, we are in danger of characterizing, thereby mistreating individuals as unwell who are not." So here she's noting that if we don't have the right concept of mental disorder, if we're not grounding psychiatric diagnosis in the right theory, then we're in danger of treating people who actually don't have some sort of disorder as if they do, which is sort of paternalistic, right? And here paternalism is this sort of like uh, it's sort of taking care of someone too much or treating someone as a child or treating yourself as knowing better than another person, right? So the problem with paternalism has to do with the worry that we will treat people as pathological that aren't, but it also has to do with this kind of conflict that sometimes exists in medicine between two of its different principles. So there are several principles in medicine that doctors try to go by. Two are beneficence and autonomy. Beneficence is do what's good for the patient, and autonomy is respect the choices and will of the patient. So we can also understand paternalism as sort of a conflict between these two. So that's another way that Washington describes it. Beneficence is trying to do what's right for the patient, what's good for the patient, but you also have to respect the patient's will and their choices, right? And treat them like an autonomous adult. So this is the worry, right? That is the influence on this paper. How do we prevent paternalism in mental health care? Washington says that to guard against treating patients as unwell who are actually well, the theory we use to ground psychiatric diagnosis must have, quote, normative authority. So what does she mean by that? She defines normative authority this way. Quote, it must speak to the interests of the individuals it is about. So, really, Washington is saying that in order for us to make sure psychiatry is not being too paternalistic, we need to make sure that the way we diagnose people is grounded in their actual interests and experiences, right? Whatever theory of mental disorder we're using has to be grounded, it has to be relevant to the actual interests and experiences of the individual. It can't be so removed from patient experience that if it is removed, let's say, from patient experience, then we have this risk of paternalism, of treating people as having a mental disorder that may not, right? Or of not respecting people's autonomy or their own interests. Okay, so Washington kind of grounds this discussion in an example, a fictional example of a person. So here is just a little part of that anecdote that she gives. She says, quote, Vincent lives alone on a remote piece of property in the Pacific Northwest. After college, he began to remove himself from his school social circles and now spends most of his time in his home making highly detailed wooden sculptures based on the suggestions of, quote, other voices. His buyers find him to be distant and abrasive and are often disturbed by his behavior and lack of adherence to social norms. So, this is an example of someone who is definitely acting in a way that is abnormal. It's not how most people behave. And he doesn't adhere to social norms. He's somewhat abrasive to others, right? So, some people might find him unpleasant to be around or something like that. He also hears voices, right? Which we might consider as statistically abnormal to some extent. Many people don't hear voices. Um, so the question here is does Vincent have some sort of mental health condition? And what criterion should we use to determine whether or not he should be pathologized, right? The worry is that if he doesn't see his condition and his lifestyle as a problem, and we say he has a mental disorder based on some objective criterion that really doesn't have much to do with his interests, then that would be sort of paternalistic, right? That would be treating us as knowing better than him. All right. So this is the worry that Washington is trying to address. And she concludes that in order for a theory of mental disorder to be grounded in concerns and interests of individual patients, it must be contextualists. It must be contextualist. So what does that mean? She says, quote, it must ground what it means to be mentally ill or mentally healthy in the concerns of the individual subject it applies to. Whatever the right normative theory has to say about Vincent, it must pay due respect to his flourishing. So ultimately, what she's getting at in this paper is the importance of, you know, the actual patient's interests must be relevant to whether or not we're calling with their condition a mental disorder. And also, it might change from person to person and context to context. So, if we're going to pathologize Vincent, it has to be relevant to his own interests, right, as an individual, not just some objective criterion on what we think a mental disorder is. Okay, so moving on to the Potter paper. It is similar in that it emphasizes the importance of listening to the interests of patients, and also, like Washington, Potter grounds her considerations in a fictionalized example of someone who is struggling with a mental health concern. So, this is the beginning of that example. Potter says, quote, "One night, a 30-year-old person of color, who I will call Eleanor, visited emergency psychiatry where she previously had been seen a number of times before. The file identified the patient as male. However, she requested that she be referred to with the female pronoun as she is transgender. She reported feelings of depression and anxiety and presented to the emergency room with suicidal ideation." Now, before I go on to read the rest of this quotation, I want us to stop just for a second and consider what are some different ways that the clinicians could respond to Eleanor. Given this clinical presentation, she comes to emergency psychiatry. What are some ways that clinicians could respond? Maybe stop for a moment and just think through, how a clinician could respond to Eleanor here. Potter goes on, quote, "This patient repeatedly expressed that she feared for her safety in the shelters, while the attending and the resident continued to refer to the patient by male pronouns, even though she had asked to be addressed as female. The healthcare team believed that the patient thought hospitalization was a way to avoid spending another night in a shelter. They assessed her as not being a danger to herself and not needing crisis intervention, therefore she was discharged." So the clinicians in this um, example, I think it's fair to say, didn't act correctly. They didn't listen to Eleanor's actual concerns or experiences. They didn't respect her identity as a trans woman, and they dismissed her concerns. So this is kind of, Potter uses this example as an example in which a patient was silenced, and she wants to sort of understand how this happens. What are the factors that go into silencing patients in mental health scenarios? So she goes on to discuss many different factors that play a role in the silencing of patients. She talks about neoliberalism, she talks about individualism, and various other concepts. And so it's a really useful paper because it defines a lot of these big concepts. But here I'm just going to focus on a few. I'm going to focus on structural violence, oppression, intersectionality, and epistemic violence. So I'll define these terms the way that Potter does, and then we can see how they might play a role sometimes in the silencing of mental health patients. So, structural violence. Quote, "Social arrangements that place members of certain groups in harm's way." So structural violence is about social arrangements, right? It's institutional. It's some sort of like big structural problem. And the problem happens to put certain groups in harm's way. It happens to do harm to certain groups, which is slightly different from oppression, which is, quote, "a particular kind of harm that is interwoven with structural violence. It is done to members of groups because they are or are perceived to be members of those groups." So whereas structural violence is this sort of social arrangement that harms a certain group, oppression is more targeted, right? It's done to members of groups because they're perceived to be members of those groups. So it's more like discrimination based on a group. It's more, we might say, in some ways intentional. It might not always be intentional, but it is directed at certain groups because they're members of those groups, right? That's how Potter conceives of oppression and structural violence. Intersectionality then comes into play. So she says, quote, "Black feminists have long pointed out that a full understanding of oppression requires recognition that race, class, and gender intersect, and hence the oppressions are overlapping. No simple formula for identifying oppressors and oppressed exists." So intersectionality is about oppression, and it notes that there are these different versions of oppression having to do with race, having to do with class, having to do with gender, having to do with sexuality, and disability, many other things. And that when someone has more than one of these identities, they might be oppressed in these different ways. And the oppression kind of builds on top of each other and mixes together in ways that can't be pulled apart, right? So, intersectionality is the recognition of these certain intersections and compilings of different sorts of oppression that exist sometimes within, one individual's experience. And Potter also talks about epistemic violence. So remember, epistemic has to do with knowledge, right? So she says, quote, epistemic violence occurs when knowledge that is possessed by subjugated peoples is superseded or discounted, or when listeners refuse to communicatively reciprocate in those interdependent exchanges. So epistemic violence happens when knowledge that's possessed by a group is ignored, right? Or not taken into consideration. Or when people just refuse to engage with it, right? So it's sort of like structural violence, but it's specifically about knowledge, right? Because it's epistemic. It's when certain groups are not listened to, their expertise or their knowledge isn't taken into consideration. And we can see how all of these factors can be applied to the case of Eleanor, right? Clearly, this is an example of structural violence because an institution is hurting Eleanor, but it's also oppression because it seems to be directed at her particular group memberships, right? It's also intersectional because she's transgender, she's a woman of color, and it seems like those things might, she's, homeless. All of these parts of her identity seem to be um, relevant to the silencing that she's experiencing. And it's also epistemic violence because people aren't listening to her knowledge, her experience, her expertise about her own situation. Right. Okay. So Potter suggests at the end a way to try to prevent these abuses, and she calls it world traveling. And this isn't literal. This isn't like go to more countries or experience more cultures, though that might be helpful. This has more to do with trying to decenter oneself and try to recognize. So suppose we're talking about a clinician. The clinician would decenter their own expertise and their own experiences and try to understand and empathize with the experiences of the patient and their expertise, and also how the patient might view the clinician and view this hospital, view this like oppressive structure that they're in, right? So world traveling, I think, has a lot to do with empathy. It has to do with trying to understand the lived experiences of other people, which, may or may not be always totally possible. But Potter is saying that this is a way that clinicians can decenter themselves and can really take seriously the experiences of patients. Okay, the last paper I'll discuss is Tekins. And in this paper, she discusses the DSM, right, the Diagnostic and Statistical Manual of Mental Disorders, and it's all about how it's created, right, how the DSM comes to be and is revised. The DSM has been revised many times over, and Tekin argues that there are epistemic reasons that patients should be included in the process of creating the DSM. So, the DSM I've discussed in other videos, so I'll just briefly say it's the book that psychiatrists and other mental health professionals, especially in the United States, use to diagnose people with mental disorders. And it's gone over several revisions, right? We're currently, I think, on the DSM 5 TR, I think it's called, that came out recently. The first DSM 1, I think came out in like 1952. So, what Tekken is interested in is this process of revision and changing the DSM. And she's arguing that patients need to be more involved in that process. We need to be listening to patients. And there have been ethical and political pushes to have patients involved in the past. But what Tekken is arguing is that there are also epistemic reasons that patients should be involved. So here's that distinction again, right? Ethically, it might make sense to include patients because involves them, right? It involves their well being. And Tekken agrees with that, but she also says there are epistemic reasons that patients should be involved. And remember, that has to do with knowledge. So the idea here is that patients have a particular sort of knowledge or expertise. She says they're, quote, experts by experience. So there's like good scientific reasons that patient experiences should be taken into consideration when we're revising the DSM. That's her main point. And a worry and a reason that this hasn't really occurred much in the past is the psychiatric field is worried that including patient voices, including patient subjective experiences, would make the process less objective, right? Um, Patients all have different experiences and different interests, so including them might make this process less objective. But Tekin disagrees. She talks about a different sort of objectivity that would actually be important in this situation, and it would require patient input. So she calls that participatory interactive objectivity. She says, quote, PIO sees objectivity as a participatory and interactive negotiation process. She goes on, quote, the process is designed to be collaborative and critically engaging. The argument for the inclusion of patients in the community of knowers and critical engagers is a natural extension of this process. To ensure objectivity in psychiatry, we must recognize and encourage the social processes of attaining knowledge and include not only the professionals with training in psychopathology, but also those with firsthand experience. So she's conceiving of objectivity as this sort of negotiation between different people that have different experiences and expertises. And she's saying if we consider objectivity to be that, right, coming to some sort of consensus, then it makes sense that we would want to understand patient experiences, right? They have a particular expertise by experience that many clinicians might not have. So if we really want to understand mental disorders, we have to listen to people that actually have them, which makes a lot of sense. Okay. So in each of these papers, they looked at the importance of including patient experience in different ways. Washington talked about how psychiatric diagnosis should be grounded in patient experience. Potter discussed the importance of listening to patient voices in the clinical encounter when, patients and clinicians are actually interacting with each other. And Tekin discussed the expertise patients can provide to the DSM revision process. And I'll end just with this question. What do you think? Do you think that it's important to include patient experiences in these ways, as these authors have argued? Or do you think there are other ways that have been left out? Or, on the other hand, do you think that patient experience should be included less than it currently is? So, what do you think about the different arguments we've considered in this video? That is all I have for this video. Thank you for watching.